I'm Vinay Prasad. I'm a hematologist and oncologist. I'm associate professor of medicine at the University of California, San Francisco. And it's my pleasure to be with you today to discuss assessing causality among super responders. I'd like to thank AACR for inviting me. And I want to assure the audience that this is definitely the first take of me recording this video. In terms of conflicts of interest, I'm the author of this new book, Malignant: How Bad Policy and Bad Evidence Harm People with Cancer. It's out now. Additional conflicts include research funding from Arnold Ventures. I receive royalties for writing this book and another book, published by Johns Hopkins University Press. I'm a writer for Medscape. I've given lectures at universities, medical centers, nonprofits, and professional societies for modest honoraria. I'm a consultant for United Healthcare. I've spoken for Evercore. And my podcast plenary session has backers on Patreon. Causality. Causality is an important and oft-discussed concept in biomedicine. We want to be able to better understand what causes what so we can interdict upon it and improve outcomes for our patients. Sometimes in life, causality is clear. Someone's running around the house, they bump into a table, a glass tips, water spills. In this case, there's no doubt about it. We all know what caused the water to spill. Super responders are something that we hear more and more about in cancer medicine. Exceptional and super responders. Patients with cancer who, quote, thrive far beyond expectations. They're paired with a therapy that they do exceptionally well to, while others may not do equally well. I think what's baked into the definition of super and exceptional responders is it's somebody with cancer who's administered a therapy to which they have a super response. They do really well. That's part of it. But the other part of it is, had they not been administered this therapy, they would have done much worse. There's something key about this therapy that leads to the better outcome. Now, there are a number of ways in science for which we can try to assess causality and whether or not super responders are really due to the drug. You might turn to the Bradford-Hill criteria. Now, this is a well-established set of criteria that's extremely useful in science. It gauges causality based on a number of factors, some of which I'll discuss are, the strength of the relationship, the temporality, did one come before the other, the consistency of the relationship, does it happen over and over again, is it plausible, is there experimental evidence that bolsters it, is there a dose response or biological gradient? These are all sort of classic Bradford-Hill criteria to better assess causality. And it turns out they are woefully inadequate to make sense of super and exceptional responders. We need something new. That's right, Bradford-Hill. It's ill-suited to super responders. I hope to persuade you of that during this lecture. And instead, I want to offer you criteria that make super responders more plausible, that their response really is due to the drug, and that they really are having a super response. So much of this lecture is going to be based on two papers we published over the last 5 years. One in the Mayo Clinic Proceedings, Characteristics of Exceptional or Super Responders to Cancer Drugs, and the other, a comprehensive review of exceptional responders to anti-cancer drugs in the literature. These are true meta-research papers that you can find and read if you're interested. These systematic reviews are really large collections of case reports of super responders. In the larger one, we're nearing 200 case reports, and we analyze them across several dimensions. And I believe if you understand how we analyzed it and why, you will better think about super responders. They'll make more sense to you. You'll ask the right questions. This is a graph that people like to show. This is an iceberg. And there's a tip of the iceberg that we see, and there's a huge sunken portion of the iceberg. And I've been to many lectures where people show such a figure. And here's what I mean to show you by this. The systematic reviews that we've done look at the published literature. They look at the tip of the iceberg. Cases where doctors, particularly oncologists, have the time and energy to publish and write up findings. Those are probably disproportionately from academic medical centers, from tertiary and perhaps even quaternary referral centers. They're cases where there's someone who's got the willpower and energy and motivation to write up this case report and the energy to submit it through many painful submission portals till it's finally accepted in a journal. And I think that's important to keep in mind. We're looking at the tip of the iceberg. What you don't see are all the cases where oncologists treat a patient. They believe the patient is doing exceptionally well. They may tell a friend or a colleague about it. They may talk about it at case conference, but they certainly don't have the energy to write it up and get it through the publication process. And I think that this leads to a skewing of the cases. If anything, I think the skewing is likely that the cases we're going to see are actually a little bit more positive than the average case that occurs in the community that somebody thinks is special. But you might disagree with that view and you might dispute that, and we can have a discussion about that, hopefully in the comments section. So what do we find? In our larger analysis, we find 180 case reports of exceptional or super responders. 274 drugs were given. And that's, of course, because we're giving monotherapies and we're giving combination therapies. And what are the types of drugs that we're giving? So here we're focusing on drugs that lead to exceptional super response. 60% of the time, they're targeted therapies. No surprise there. A third of the time, they're cytotoxic drugs, and that may come as a bit of surprise to people. These are patients who are thought to do remarkably well from some cytotoxic drug. And about 7% of the time, these were immunotherapy agents, such as the PD-1 class of checkpoint inhibitors. And I think that might be in part due to the fact that, whenever you do a systematic review, it's inherently based on literature that preceded it. And checkpoint inhibitors are relatively new, at least in terms of when we perform these studies. 93% of these drugs were FDA approved, but 7% were experimental. That means they had not been approved for any purpose. In terms of specific drugs, of course, kinase inhibition rises to the top. 48% of all drugs that people thought were a drug that led to a super response were kinase inhibitors. And the most common places that they're inhibiting are BRAF, VEGF, and EGFR, in that sort of breakdown. Monoclonal antibodies were another class of medications that were frequently discussed, and inhibitors of mammalian target of rapamycin, that's about 15%. So that's a significant chunk of super response attributed to things like everolimus. What's about the depth of response? If you look across many hundreds of published case reports of super responders, what is the depth of response? And what you find is about a third of the time, it's a complete response. 55% of the time, it's a partial response. And about 8% of the time, it's stable disease as best response. Now, I think stable disease as best response is quite disappointing. That could easily be indolent biology just running its natural course, and we're going to talk a little bit more about that as we further dive into these cases. Complete responses, now that's something that usually gets our attention as oncologists. Notably, 17% did not even tell you what the depth of response is, and I think this is a notable omission, which is something we're going to talk about a little bit later. What about prior lines of therapy and median duration of response? So it turns out the median duration of response among all the published case reports of super responders when you do a systematic review is about 16 months. The number of prior lines of therapy varies widely. This histogram, which is being blocked a little bit by my face, shows you that there were some fraction of it that has 0, a lot with 1 prior line of therapy, and a few, this tail runs out to actually 10 in our largest series. So this just gives you some sense of what the sort of distribution of prior lines of therapy is. But, there's quite a range here, and there are some super responses that are being attributed with no prior lines of therapy, but in most cases, there's probably at least 1 or more prior line of therapy. And that's important. We'll come back to that. 18% of patients who are called super responders, when you read the case report, you realize they didn't just get the drug. It was paired with something for oligometastatic disease. Like they got the drug, and then they got radiotherapy to a few sites of disease. That's an important thing to keep in mind, because when you assess causality in terms of what the drug did, you've introduced a confounding factor, which is that you're doing something else to the patient. Now, a little bit to the types of people who are pursuing the publication of these studies, many of these actually looked for putative driver mutations. About 60% of these case reports identified a putative driver mutation, or they could hang their hat on something they thought was the reason why this drug was working so well. And 40% of authors actually performed additional correlative or translational studies to bolster the claim that this mutation was in fact oncogenic, and that inhibiting that mutation perhaps was able to impair oncogenesis and slow the growth of cancer. And that's very notable that it happens in a fraction of cases, not all cases of course, where authors are willing to go that extra mile to try to explain to you the pathophysiology of why this drug is thought to be working so well. One thing that's worth noting is the median duration of response to a prior drug when it was given was 8 months. And the median duration of response to the exceptional drug, the super response drug, was about double that, 16 months. We're going to come back to that. Interestingly, the NCI's Exceptional Responder Initiative defines an exceptional response as someone who had at least a CR or PR with a duration of 6 months. Notably, when we look through the biomedical literature, the creme de la creme of publications, we find that 16% did not meet even this modest criteria. I'm going to talk a lot more about missing data. So who provided data? So my face is blocking the key portion of this figure, so I'm going to move myself up. Okay. 100% of cases provided the histologic type and the cancer diagnosis. 94% of case reports told us the duration of response. 92% told us the age of the patient. 86% told us the number of prior lines of therapy. 82% told us the depth of response. Did you get the CR, the PR, or did you merely get stable disease? The best duration of response to a prior single line of therapy was only given by about 60% of case reports. About half of case reports even told us how long the patient had had metastatic disease. About half of case reports told us what year the patient was being seen. And only a paucity of cases, 14%, told us the number of patients who had to be treated similarly to observe the response. By that I mean, if you're pairing patients based on NGS assay, how many patients did you run the NGS assay on and provide drugs before you were identifying the super response? If you gave somebody a targeted drug for a certain condition in the relapse refractory setting, how many similar patients did you treat that way before you observed the super response? This question really cuts to the heart of the question, which is, what is the denominator? How many people do you have to treat to elicit or see the super response? And we find only a tiny fraction of case reports are giving us this information. Let me give you one example of an actual case that we found in our literature review. This is a 71-year-old woman who suffers from anaplastic thyroid cancer. And I think we all recognize that this is a dire prognosis. Median life expectancy is arguably between 4 and 6 months. This is a grave prognosis, and we don't have terrific treatments for anaplastic thyroid cancer, even to this date, even since this case report, obviously there's been an approval of BRAF drugs, but still, we still lack good treatments. This patient was identified with having a ALK mutation that was thought to be a driver mutation. The patient had a 6-month duration of response to crizotinib. I know what you're thinking. That's quite impressive. We're talking about anaplastic thyroid cancer. But when you dig deep into this paper, you discover something that's a little bit in the heart of the paper, and that's that this patient lived 2 years with the diagnosis of metastatic anaplastic thyroid cancer prior to receiving crizotinib. And I think that's a salient fact when you're trying to decide whether or not crizotinib is drugging ALK and leading to a super response. You already have a patient who has outlived the life expectancy of this condition and is likely already on the tail of the curve. I haven't calculated her precise percentile, but she might easily be upward of the 90th or 95th or 99th percentile of outcomes of people with this diagnosis, even prior to her receipt of the quote-unquote super drug. This is a wonderful figure that was put together by Jia Lu, who's now a fellow at Memorial Sloan Kettering Cancer Center. This is a plot of, in all the case reports in which we could put together this plot, where they gave us enough information. This is sort of a swim lane plot of every patient. And what it shows you in green, in gold, and in blue is whether or not they had a CR, a PR, or stable disease to the quote-unquote super drug, the super response drug. And what it shows you in gray was the prior duration of time that the patient was documented to have metastatic disease prior to getting the super drug. And you see that they're different cases. You know, this person here, they progressed quickly and then had a longer period of time in CR. That intrigues me. That makes it seem to me possible that there's something to this story. This person here had a long time that they've been treated successfully with different medications. Finally, they get a drug where they're labeled a super response. They've at best achieved stable disease, and it's a tiny fraction of their metastatic journey. This is one where I wonder whether or not perhaps we're talking about wishful thinking. And if you look across this plot, you see there are many cases that make you worry, is that wishful thinking, or is that really a super response? The von Hoff plot. Now, Daniel von Hoff put forth a definition that I think many of us know and recognize, which is one way in which we can identify someone doing exceptionally well from a novel drug is to see if their PFS on the novel drug is superior to a prior PFS. Now, in general in cancer medicine, as a very general rule, PFS gets shorter with subsequent lines of therapy. Von Hoff says if your PFS on the new drug is about 1.3 times better than a prior PFS, that suggests to me there's something perhaps special about the new drug. So here I show a plot of the length of response to the exceptional drug on the y-axis, the length of response to the best prior drug that was reported in studies that reported this, on the x-axis, I've plotted the von Hoff line. And I'm asking the question, how many of these case reports are falling left of the von Hoff line or above the von Hoff line? How many of them are falling to the right or below the von Hoff line, meaning that they fail to meet even the modest criteria put forth by Daniel von Hoff? And the answer is only about half of these case reports that we found through systematic search of the literature, that people took the time and energy to get to publication, exceed the very modest threshold set by Daniel von Hoff as a super responder. So I think whether or not wishful thinking is occurring among many case reports of super responders is something that we have to grapple with as scientists. You know, one of the things that I'm often subject to as an audience member in many of these lectures is the dramatic outcomes on scans. A patient who gets treated with a drug and you see a PET scan look marvelously better. And here I've shown you PET scans from a drug that failed in phase 3 testing. It is not on the market. And the reason I show you this is to remind us that even failed drugs do have some remarkable PET scans. And so the real question is, can you come up with a treatment strategy that as you deploy it going forward, do you improve outcomes on average for your patients? And that's really what we're trying to ascertain with exceptional super response. We're trying to take this information, use this information to come up with treatment strategies that leverage improved outcomes for all our patients. That's the whole scientific pursuit of this. So what makes for a strong causal claim? So these are my rules for exceptional and super responders, and I'm going to move my picture down here a bit so you can see it better. Okay, so first, 0. 0 is a big problem. So when you think about an exceptional and super response, you have to first ask yourself, how many prior lines of therapy did this patient get in the metastatic setting? And if the answer is they've never received a prior line of therapy, you got a big problem, and I'm going to tell you why. If they've gotten one or more prior lines of therapy, I think your task is a little easier, but it still isn't easy, and I'm going to try to convince you of that. So 0 is a big problem because of this fact. If the patient has never received therapy for metastatic cancer before the drug that you think is a super drug causing a super response, you're not permitted to do an intra-patient comparison. You can't compare PFS for that person on that drug to a prior PFS because that, by definition, does not exist. So you can't compare duration of response to prior duration of response. You're limited in one fundamental way of comparison that might be useful to try to make some causal sense out of this situation. And you're also troubled by the iceberg problem. You're just looking at the tip of the iceberg. You're not seeing all the people who you're giving that drug to who might not be doing exceptionally well. And the question is the patient doing exceptionally well because there's something to the patient's biology and that drug that's a match made in heaven? Or is the patient doing exceptionally well because they were destined to be the fraction of people who do well on any single thing you give, including the fraction of people who do well when you do nothing? So these are two Kaplan-Meier curves that I think are really notable. The left curve are patients with lung cancer, and this is from a paper that, tried to show that patients who choose alternative medicine and forego all traditional care, they do poorer than patients who agree to at least some Western medicine. And I think that's something that most oncologists who are listening to this, they're not going to need to be persuaded of. And I didn't need this study to be persuaded that it's probably not a good idea to neglect lung cancer altogether, that our therapies do work. And the type of person who's going to pursue alternative medicine and not get any traditional care, that's a unique type of person, we can't forget. But I show you this Kaplan-Meier plot just to point out that at 84 months of follow-up, people with lung cancer who pursued only alternative medicine and no traditional medicine, there is some fraction that's still alive. And this curve on the right, these are patients with metastatic melanoma who I believe are candidates for some anti-tumor vaccine that I don't know anything about because it was never successful and never came to market and we never used it to this date. So this is something that I would consider a largely failed class of medication, that it didn't work. And what you see here is that decade by decade, between the 70s and into the 80s and 90s, the survival for stage 4 metastatic cancer patients who are being treated with this useless treatment, it's abysmal, it's dismal, and thankfully we've made progress since then. But what I want to show you here is that even with a follow-up of, I believe that's almost 60 months, 5 years, that there is a fraction of people who are still alive. So what's the point here? The point here is that If you're allowed to only look at the tip of the iceberg, if you're allowed to only look and see who does super well and forget about all the other people you're treating, whether even when you give somebody something that does absolutely nothing at all, a useless vaccine on the right or alternative medicine that's not doing anything on the left, there's going to be somebody who lives that long. And so the challenge with assessing causality in patients who have never received prior therapy is you really don't know if you're just looking at the natural, inevitable tail of the curve that happens even when people get nothing at all. And here I've shown it with a blue arrow. So, what I think for my rule, Prasad's rules for super responder causality when patients have no prior therapy, is I think you really want to see that the patient got into complete remission. And anything less than that is going to be suspect. If they didn't get a complete remission, they just had partial response or stable disease for many years, I'm really not going to have any sense whether or not the drug has any activity or any unique benefit, or that you just happened to find somebody who had indolent biology. They were destined to do well anyway. I think it would also help me to know that CR occurs infrequently with standard therapies. Here I've shown less than 1% to show that, you're getting a CR and CR is exceedingly rare. And I think I have to have something quite stringent because you have the ability to look through as many examples as you can. You have the luxury of multiplicity, and therefore I need to set a very stringent bar to take you seriously, knowing that you have the potential to have fooled yourself by just picking somebody who happened to have a CR in cases where CRs are not infrequent. If they occur at 5% of the chance with standard therapies, it's not so hard to find a CR. Okay, so these are my first two rules. The next two rules, I think, these go hand in hand. I think duration of response has got to be the 99th percentile or better. It's not good enough to show a CR that's fleeting. You're really going to have to show me something incredibly dramatic, a long duration of response. And you got to also show me the duration of response with standard therapy at this length is also infrequent. I think that will help me believe that this new drug is actually doing something. You need logical correlative studies, strong translational science. You need to team up with somebody who's exceedingly good at thinking through translational biology and building me the kind of story that can be well published in Nature Medicine or Nature. That's the kind of story that I'm really going to want to see. I also want to see a long overall survival. Of course, living longer, living better, those are the only two things that really matter to people. I want you to see that. And then here is the key for me. When you're really coming to me with somebody who has received no prior therapy, it's going to be important to me, I'm going to move this out of the way, that you extend your paradigm to 5 to 10 additional patients with molecular abnormalities, similar molecular abnormalities, who all benefit better than 75% of standard of care. What do I mean by this? I want you to take the things you've learned from your exceptional and super responder and show me that in sequential and non-selected patients going forward, you can recapitulate these results. Now, this is one of the classic hallmarks of Bradford Hill that I'm co-opting to some degree, which really says that, sometimes one case report might not be enough, and you might have to find an additional patient and treat them to really bolster that claim. Now let's talk about the situation where you have a patient who's received at least one prior therapy. Well, you get a luxury here. You're now permitted to do an intra-patient comparison. You can compare outcomes on the super therapy to prior therapies. But you still suffer from the iceberg problem. You still have the luxury of looking just at the tip of the tip, the creme de la creme, the cases that happen to catch your eye, and you may forget the large mass beneath. You still have the ability to cherry pick somebody who happened to be on the tail of the curve. So here's what I think would help in this situation. Complete remission, strongly preferable to PR or anything less. You're really going to come at me and you're going to tell me that this is a super drug that has a super response. I'd like to see something that's truly dramatic, a CR. Again, I want to see that CRs occur infrequently with standard therapies. I want to see your response, your depth of response. I want to see that it's deeper than prior responses. You're going to persuade me more if you show me somebody who had stable disease on a taxane, stable disease on a second-line therapy, and then finally had a CR with your drug. That's going to be persuasive to me. I want to see duration of responses that at least meet the von Hoff threshold, 1.3 times prior response. I want to know that duration of response, the duration you're showing me, occurs exceedingly infrequently among standard of care. Again, I'm going to like logical correlative studies. I'm going to like to know the patient had a long or prolonged overall survival. And again, I'm going to like to see you extend the paradigm to 5 to 10 additional patients with a similar molecular abnormality, that pathophysiology story you elucidate. I want you to Prove to me, sequentially and in a non-selected fashion, that you can extend this paradigm to the next patient coming into your office. And you do all this, I think you're well on your way on Prasad's rules of causality for super responders. In both of these cases, I think it's going to be really important that you don't give me a case report where the patient was administered a confounding treatment. I don't want to see that the patient is a super response when you gave him a drug and you're radiated at 3 sites. I don't want to see the patient's a super responder when you also consolidated with an allo transplant. And the reason I say this is, in fact, many cases of super response do exist with these confounding treatment events, and I showed you that in an earlier slide. As a corollary, I think it's going to be very difficult to show exceptional or super response in the adjuvant curative setting. So please, no super responses for folks that are undergoing curative surgery. If you give a drug that you think is having a neoadjuvant benefit, you perform surgery, you can't just say the patient did not recur and let me believe that it must have been the drug that did it. Because the truth is, even in advanced stages, often there is a fraction of people who do not recur from surgery alone. It is a curative treatment. How do I know that your drug is conferring an additional benefit? I don't, and it's going to be very difficult to do that based on an anecdote or case report. So, Prasad's rules for causality with exceptional super responders, they're fundamentally concerned with deducing, is this outcome the product of selective reporting or chance among patients with natural indolent biology who are destined to do favorably? Or has your novel drug truly done some heavy lifting and fundamentally changed the trajectory of outcomes? And to apply these rules, we really need uniform reporting standards. In the paper by Jia Liu and Go Nishikawa and myself, we have outlined a set of characteristics that really should be part of a universal reporting form, standardized reporting criteria for super response. These should include tumor characteristics, patient characteristics, characteristics of the response, and correlative studies that are being done. And again, a note about whether or not confounding variables like other treatment modalities were administered. The last thing I'd say, and then I'm going to pay credit where credit is due, is that conflict of interest plagues this space. We have shown in a publication that the more conflicts authors have, and of course the majority of authors have a conflict either to the drug or the test, the more conflicts authors have, the more they are to omit information that I believe is important to assess causality. And one can only speculate as to why that association, which is a true documented association, exists. So, in terms of credit and further reading, I'd like to credit Jia Liu, who is now MSKCC Fellow, and Go Nishikawa, who is applying for Hem/Onc Fellowship right now and is a terrific candidate. You should interview this gentleman. These two did the lion's share of the paper on the right. Andre Vandross, who is a faculty at Next Oncology in Texas, did the lion's share of the paper on the left. And people who are really interested in this topic can enjoy Chapter 8 of Malignant. Thank you so much for your attention.